Let me ask the panel this. Medication is a routine and the most prevalent means by which we prevent and control chronic disease.
Oh, that's right.
But we read stats all the time
I'm sorry.
and time again that show a large number of individuals with these chronic illnesses do not take their medication as prescribed.
Back and forth.
Including in the chronic care legislation is a provision that directs the Government Accountability Office to study the extent to which Medicare prescription drug plans use programs that synchronize pharmacy dispensing so that individuals may receive multiple prescriptions on the same day to facilitate comprehensive counseling and promote medication adherence.
Okay.
As a longtime champion of medication therapy management and through the work I have done with Senator Carper, who has taken the lead in this, and I thank him for that, on identifying and strengthening other medication adherence strategies like MTM and MedSync, I want to ensure that we're targeting these adherence efforts to the patients that will benefit from them the most. Do you have any recommendation, any person on the panel, for us to consider within this chronic care package or in further legislation that will help us ensure we are targeting the right patients to improve adherence? Dr. Schwab, do you want to take a shot at that?
Yeah, you know, every visit that I have with a patient, the first part of the visit is we go over the medication list to make sure that it's accurate in our health system. And I would say that more than half of my patients are on at least 1.5 pages of medicines. And we go through each one, and half the time they can't even tell me what the medicine is for. They just recognize the name, and they tell me that they take 1 or 2 pills of it. We know that for every additional medicine a patient is prescribed, their adherence to the regimen goes down. So the more you're on, the less able you are to take it. And if patients use something as simple as a pill dispenser, so filling up the pills, you know, on Monday for the whole week, they increase their likelihood of adherence. It seems crazy to me that we don't invest more money in making sure that the therapies we know are proven to be effective when taken routinely get taken routinely. So again, I would encourage the committee to try to target the patients who have the conditions for which we have the best evidence that these medications reduce the risk of rehospitalization, major adverse events like stroke and heart disease and heart failure, and work hard to strengthen programs that will encourage us to build new and innovative systems for ensuring that medication adherence is happening.
I appreciate that. Anybody else would like to comment?
Well, I would just,
Yes, sir.
just add to what Dr. Schwam has said. One of the things we do, because it's very difficult often for many physicians to reach out to large numbers of their patients, we use a number of PharmDs, and they go out and help patients because, as we pointed out, many of them have as many as 8 to 10 prescriptions with the goal of trying to appropriately outline a plan using these pharmacists to work directly with the physicians to best manage the medications the patients are on, because it enhances the compliance ultimately and avoids unnecessary medical consequences. So we have added that.
Dr. Lovelace, you indicated you had a comment.
Thank you. Yes, we do similarly have a lot of use of extenders, pharmacists and nurses particularly, to interact with patients and other physicians around complicated regimes. Now, the 3 quick questions to ask people, I think, in this complicated process are, do you understand why you're taking this? Can you afford to take it? And does it make you feel bad in some way? And if the answer to any of those things are, no, I don't understand, or yes, it makes me feel bad, then people don't do it. Adherence rates go way down. So the opportunity to sort of get a more direct interaction with the patient around the experience of the drugs. Many people, as Dr. Schwab said, they have 8 medications prescribed by 7 doctors. So only the patient knows the whole regime, not the prescribers. The pharmacist has an opportunity to pull that all together.
What about over-the-counter? Seniors watch TV a lot, and you see all of these ads that say very positive things about the medication they're trying to sell. Maybe that's not putting it accurately, or promote. And then they always list everything that could happen to you at the bottom. But I think probably a lot of seniors go in and buy these products, adding to their prescriptions. The mix of that, I'm not too sure works very well. Would you comment on that and how we could get our arms around that one?
Well, I'm not sure I can tell you how to get your arms around it, but I think there is a misperception that things you can buy over the counter are not drugs or medications. And I counsel my patients frequently that they need to tell me everything they take on a regular basis, including things they buy in the health food store or what we might call non-traditional medications, because many times patients may be taking things that interfere with the effectiveness of the treatments we're trying to get them to take. And as I mentioned before, it's the number of things you take every day that lead to you not taking them regularly. So that includes over-the-counter medicines as well. And we know that over time, we discover that there are harmful effects for many of the things we presume to be benign or only have beneficial effects. So I think this polypharmacy is the name that is used sometimes to describe this mixture of medications. And the idea of reconciling those medicines and looking for interactions between them is incredibly important. If you practice in an integrated healthcare system, the software that you use to prescribe medicines will often alert you to dangerous interactions between medicines that you might not have been aware of. So I think anything we can do to strengthen the support at the time of prescribing and at the time of visits that will help providers and patients understand dangerous interactions between medicines is very important.
Okay,
I
Senator.
thank you for that. My time has expired, and I just want to thank again Senator Carper for working with me, and I'm working with him on this legislation. Thank you.
Right, Senator Stabenow.